Hello and welcome to 5-Minute Nephrology. I am Dr. Nephron because anything saltier would be bad for your health. Today we're going to talk about post-strep glomerulonephritis. What is the definition of PSGN? It is characterized by immune-mediated glomerulonephritis, most commonly occurring after a strep infection. It can occur after other infections as well, but strep is the most common. It is characterized by acute nephritic syndrome, which is hematuria, proteinuria, edema, and hypertension. Low complement, specifically C3, is a classic laboratory finding. Here you can see the complement system. Over here you have your alternative pathway, which is the pathway that is affected in post-strep glomerulonephritis. And here you have that C3, where you have that constant C3 tick over into C3BB, eventually leading to the membrane attack complex, as compared to the classical pathway where you have the C4 or C2, and that's where you would see something like in lupus, where you have both C3 and C4 being low. In post-strep glomerulonephritis, it typically affects predominantly the alternative complement pathway. The epidemiology of post-strep glomerulonephritis is the most common cause of acute glomerulonephritis in children, with a peak age around 5 to 12 years old. It often follows a group A beta hemolytic strep infection, around 1 to 3 weeks for the throat infection and 3 to 6 weeks for the skin. The way I remember that is the further away from the kidneys you are, it takes a little bit longer to get there. It is decreasing in developed countries worldwide, but it is still common. Pathogenesis is formation of circulating immune complexes. You also have nephrogenic antigens such as strep pyrogenic exotoxin B, SBEB, and NAPIR, which come from a strep infection and deposit in the glomerular basement membrane. These antigens combine with antibodies to form immune complexes both in situ, which cause complement activation due to molecular mimicry of the M protein, followed by inflammation leading to hematuria, proteinuria, decreased GFR, and of course hypertension and edema. There does seem to be a genetic predisposition with various HLA, but it is not definitive. Clinical features are acute nephritis with gross hematuria, typically cola-colored urine, periorbital or generalized edema, hypertension, reduced urine output, along with AKI. What are the lab findings? Low complement levels, specifically C3 like we discussed earlier, elevated ASO or anti-DNase B if it is a post-strep glomerulonephritis, with dysmorphic RBCs and RBC casts, meaning that it's coming from the glomerulus and not the lower urinary tract, and mild to moderate proteinuria are typical. Differential diagnosis includes IgA nephropathy, lupus nephritis, C3 glomerulopathy, IgA vasculitis, and Alport syndrome. IgA nephropathy, the hematuria usually occurs during the infection, and complements are normal. In lupus nephritis, both C3 and C4 are low, as well as having other features, like a positive ANA and double-stranded DNA. And in C3 glomerulopathy, you usually have persistently low complement levels. IgA vasculitis comes with other things, such as a purpuric rash and abdominal pain. Alport syndrome usually has hematuria, proteinuria, family history, as well as hearing loss and vision loss, depending on the mutation. Differential diagnosis based on complement. So you can see where the C3 and C4 are both normal. So something like, say, like pauci-immune vasculitis, like ANCA vasculitis, IgA nephropathy, IgA vasculitis, anti-GBM disease, Alport syndrome, etc. With a low C3 and normal C4, you think post-strep glomerulonephritis, C3GN, which we'll talk about, as well as dense deposit disease. And where the classical pathway is activated, we talked about earlier, lupus nephritis and immune complexes, PSGN may be possible. Here we have a case example, an 8-year-old boy with facial swelling and cola-colored urine, recent strep infection, UA with hematuria, elevated urine protein creatinine ratio, but it is subnephrotic, mild AKI with low C3. The blood pressure is elevated. The UA with hematuria and RBC casts, the urine protein creatinine ratio is 0.9. He has mild AKI. And the diagnosis most likely is going to be post-strep glomerulonephritis. And in a typical presentation like this, you do not need a biopsy. What is the treatment? Antibiotic therapy is typically given to reduce the strep antigen burden. It's primarily supportive care otherwise, such as salt restriction, diuretics for edema, blood pressure control. In severe AKI, dialysis may be required, but it is fairly unusual. Most children recover completely. The GN usually recovers within about 1 to 2 weeks. However, microscopic hematuria and proteinuria can last for quite a long time, so that's something to be aware of if checking your analysis. C3 typically recovers within about 6 to 8 weeks. However, if it is still low after 12 weeks, you have to consider a biopsy because then you are considering other diagnoses, such as PSGN, specifically C3 glomerulopathy, where a persistently low C3 is key to the diagnosis. Some of the key points: antibiotic therapy does not eliminate the risk of PSGN as opposed to rheumatic fever. PSGN is the most common cause of acute GN in children. It occurs 1 to 3 weeks after strep infection, or 3 to 6 weeks if it's a skin infection. Low complement is a key diagnostic clue, particularly with normal C4. Management is usually supportive, and the prognosis in children is typically excellent, and it does not recur. And here you have some more references if you want to take a deeper dive, and that's your 5-minute nephrology on post-strep GN with Dr. Nephron. Until next time, you're in good hands with renalforresidents.com.